Thanks for all the faculty for coming here. And thank you, Dr. Sturm, Dr. Viral, Dr. Arvind Jaishwal, Dr. Raghav Dutt, Dr. Suresh, Dr. Nane, Dr. Abhishek, and Dr. Marius. I will start the session with Dr. Arvind Jaishwal and Dr. Nane moderating the session. The first session will be on early onset scoliosis.
Talk on early onset scoliosis. Senthil, will you introduce him, please?
Yeah.
Thanks to you, Senthil.
Thank you very much
in
for
this meeting, because the topics that are going to be discussed today are very unique, and many of us are not, so much adept and good at it. And I think we have the, the top experts here, and I think we should make the most of it.
So the first talk will be on early onset scoliosis, why we need to treat. As we know that when you look at the literature and we go through that, we see that the early onset scoliosis kids have a very low quality of life scores, which means that they need treatment, it needs to be addressed to survive and to keep them comfortable. When you compare the scores, it's low when compared to common diseases like asthma, JRA, and heart transplants. They also have a compromise in spinal growth because most of the spinal growth occurs during the first 5 years of life, as we see. And because of there is a scoliosis, there is a huge compromise in the spinal growth and the thoracic volume. Because as the thoracic volume diminishes, the lung volume also diminishes. Hence, their life expectancy is way too low, which needs to be improved. When you come to the assessment of early onset scoliosis kids, during the early phase of the first 5 years, the lung starts to develop well. The functional capacity of the alveoli increases, and the pulmonary parenchyma also develops much. Since because they don't have the adequate thoracic volume, the formation of alveoli is impaired, and there is atrophy of the pulmonary parenchyma, leading to increased work of breathing. They spend a lot of ATPs to work on the breathing pattern, and they have an abnormal VP ratios, resulting in a lot of deaths in patients who have early onset scoliosis. So we need to treat these kids basically because, one, to improve their spinal growth, two, improve their life expectancy, improve the quality of life, four, to develop near normal alveoli so that they can sustain and decrease morbidity and mortality in this population. So we will continue on the lecture on early onset scoliosis with the cast.
Early onset scoliosis, we are fighting growth. And unlike the standard scoliosis that we treat, here there's a huge growth factor left which can take you one way or the other. And predicting that and trying to harness the child to grow at the same time, not deform, is the challenge that faces us. And honestly, amongst the spine surgery fraternity, early onset scoliosis, also known as EOS now, is probably the most unsolved of the problems. It's the most unresolved problem, and no matter what you hear today and how many things you read about it, there has been no cookbook or no one-stop shop or no solution to this challenge. So everyone's just trying their bits, and everyone's trying to throw in their hat in the ring and proposing a solution. But as you can see, because the growing years of the kids can really deform the spine, and either you have to play in for a short straight trunk or a deformed and growing trunk. So we look forward to hearing from the expert.
Inviting us and including us in this course. I'm going to talk about casting and early onset scoliosis this morning. Senthil touched on the early onset group. So infantile less than 3, juvenile 3 to 10. Early onset, really, we talk about kids under age 6. And I think the take-home message is big curves in little people are a huge problem. This is what we want to avoid. Senthil touched on this, the increased mortality in kids with early onset scoliosis. Severe curves affect the space available for the lung and alveolar growth. What we know is that it's probably different genetics than adolescent idiopathic scoliosis, though we don't really understand the genetics. Left thoracic curves are more common, and in early onset curves, more common in boys than in girls. About 20% incidence of intraspinal pathology, so even in things that appear to be idiopathic, it makes sense to do an MRI and look carefully. And I think that Min Mehta is really the one who has brought this to the forefront, made people really think about it. Mehta's angle greater than 20 degrees, curve greater than 30 degrees are predictive factors of progression. And a lot of these kids aren't really truly idiopathic. They have some funny syndrome going on, and a syndromal curve increases the incidence of progression significantly. And Mehta's angle, again, ribvertebral angle difference between one side and the other. The good news is that 90% of these curves resolve by age 2 spontaneously with no treatment whatsoever. The bad news is that 10% don't, and those really are a big problem. There's no evidence whatsoever that bracing works in early onset curves. No evidence in the literature. Most people in the States have gotten away from bracing. There really is no evidence anywhere that it helps. So the non-surgical treatment then is really casting. Risser casting is, I think, of historical interest, and then the Cottrell, Mehta, or EDF cast, I think, is what most of us are doing in this day and age. Risser casting was initially used for adolescent idiopathic scoliosis. It was based on 3-point pressure, the same way as braces are. And the problem is in plastic growing spines and plastic growing chests, the 3-point pressure caused significant difficulties, mostly chest wall deformities. So you can control the curve but deform the chest. And since we're doing this to try to maintain lung function, deforming the chest is really a big problem. EDF casting was originally introduced by Cottrell in France for adolescents. Mehta adopted it in England for use in early onset scoliosis. It's gotten more and more popular in the States, and there were initially a few of us who did it, and now I think there are more and more people in most major centers who are doing it. This is what it looks like. This is what the x-rays look like. This is a child pre-casting, and then after casting was finished out of the cast. So there's a table that we use. It's called the EDF table. It's available. It was originally made in Malta. There are a couple of different versions that are available now. Child is put on it, traction's placed, the cast is placed. We roll a plaster cast first, and then do this corrective derotation maneuver, and then fiberglass over the plaster just to make sure that the cast is going to last, and cut the windows out like this. Window in the front so they can eat and breathe, but we do this mushroom shape so that we control the lower ribs so those don't pouch out each time the kid inspires and expires. And that window in the back is for derotation. So if we're pushing up on one side, we want the spine to derotate down on the other side. Protocols of cast is based on age. For kids 2 and under, we change the cast every 2 months, 3 and over every 3 months, and 4 and over every 4 months. We cast until the curve is either completely gone or stabilized, and then brace for 1 year after correction. This was our initial paper that we presented. 53 patients, progressive curves, more than 1 year follow-up from the initiation of casting. All but 5 of the patients responded to the casting. 6 patients had undergone surgery when we published the paper. 4 because of worsening, and 2 because the parents said enough is enough, we just can't do this anymore. Space available for lung improved from 0.89 to 0.93. No patients experienced worsening rib deformities. So in my hands, I do this even in some kids up to age 5 or 6. And those kids, I don't really expect that we're going to get correction. And kids who are really looking to get correction of the curve, I think the best group are kids under 3 and kids who have really, truly idiopathic curves and whose curves are under 60 degrees when we start. And I think all the studies have shown that in those kids, you actually can correct the curve completely just with the casting. And I don't think this is rocket science. I think what we're doing is taking the curve, pushing on it, correcting the curve, and holding it corrected in the cast. And your most rapid growth period is between 0 and 3. So I think all we're doing is taking advantage of these kids' growth. So as they grow, if we hold the curve straight, unload the concave growth plates, they can grow out of the curves if the curves are small enough and they're young enough and they have enough growth left. We just presented this at SRS. This was from Miners in Chicago. 74 patients entered serial cast treatment between 2005 and 2012. 28 currently casted, 30 completed cast treatment and converted to a brace. 9 were treated surgically, 6 were lost to follow-up. In the patients currently casted, 19 who had idiopathic scoliosis had a decrease in their Cobb angle from 47 degrees to 27 degrees at the time that we looked at them. And interestingly, the rib vertebral angle difference was not predictive of correction. So we could really not figure out which of these kids were going to respond the best based on rib vertebral angle difference. But in all of our experience, most curves respond, patients tolerate it well. Chest wall deformity does not seem to be an issue with proper casting. And again, the key is no 3-point pressure. What we do, and as we showed on the slide, we roll the plaster cast. As the plaster dries, you push up on the apex of the deformity from behind, not across the chest, but push up on the apex, push down on the pelvis on the other side, and try to derotate the patient around relatively gently. Traction beforehand helps the correction, and then that derotation maneuver, I think, really avoids the chest wall problems. Spines seem to remain flexible, and even in the kids who we know, so if I have a 3-year-old with an 85-degree curve, I'll put them in a cast and try to get as much time as we can, and as long as the families can deal with it, we can cast these kids till they're 5, 6, 7. I'd much rather, Viral will talk about growing rods in a minute, but I think all of the growth systems we have now, even the magic rod, the longer we can put off intervening surgically, the better off these kids are and the better they'll do. So if we can carry these kids, even kids with very large curves, as long as the curves aren't getting worse, if we can carry them until they're slightly older, I think we've done them a favor. So smaller curves, 60 and under, and kids who truly have idiopathic scoliosis under age 3, I think we can cure them with casting. Kids older than that and with bigger curves, I think we can delay surgical treatment. And I think there's a little bit of a debate about whether or not that's a good thing or not. Senthil referred to the alveolar issue. Some people, Bob Campbell among them, believe that if you intervene earlier, we can probably make more normal lungs. The problem with that is that the complication rate from our intervention is enormous, and I think the longer rods are in, the higher the complication rate. So that's the trade-off, unfortunately. So I don't think we're there to whatever the next device is going to be that's really going to improve our treatment of early onset scoliosis. But until we get there, I think this is a great way to try to delay surgical treatment. Best for kids under age 4, holding action to delay surgery. True idiopathics respond best. Thanks.
If you can stay there, sir, we could take some questions since the next talk is completely different.
6 months. I think under that it's just difficult to keep the cast on, but we've casted kids as young as 6 months. I think that's about the best age to start.
Is there any criteria like weight, child's weight, or
not
pulmonary function?
No. So I think, again, we're still casting, as far as an upper limit, where there are kids who are 5 or 6 who are still casting. And in a lower limit, I don't think there's a lower limit at all.
How often would how would you decide when you want to change the cast? And
so again, if the kids are under 2, we change it it's based on age. Under age 2, we change it every 2 months. Under age 3, we change it every 3 months, and 4 and over, change it every 4 months.
And specifically for all of benefit, what are the specific instructions you'll give the mother in terms of?
It's easy for the kids. You saw those pictures of the kids running around. It's easy for the kids. It's a pain for the parents because you can't get the cast wet. So they need to sponge bathe them. We've not had problems with skin breakdown. I think you need to be very, very careful about how you pad the cast. And if anybody here is ever interested in casting, we're happy to help you get started, either coming to the States or we can come show you. We're always happy to pass this technique along. You have to be very careful about how well you pad the cast. That's key. You really need to pad the cast well. We take the kids out a week before we put the new cast on because I think it gives the skin a chance to breathe. Parents get to bathe the kids, and we've not had problems with skin breakdown. But I think that's what, you really have to be careful about how it's like anything else. You have to do it right, and you have to be careful. But I think if you are, it's a great technique.
Do you have a special table for that, or
Yeah.
how do you take the?
So initially we started using the old wrister table, but it's just so big it's hard to work around. So there's a table, again, that's available. It was originally made in Malta, but now it's made in the States in various places. And that's what we showed the slide. So it lets you, there isn't a strap. There's a board. We put them down, there's a board that pulls out. And we put pelvic traction straps on the same way as you used to with the wrister and a head halter. And there's a bar that supports them under their butt and and you can either hang their feet up or put a bar under to support them. So their torso is completely free. So you put enough traction on just to help with your correction. You don't overdo the traction. Put a little on the head, some on the pelvis, and then you put the bars underneath. So their torso is completely free, and that lets you roll the cast.
The wrister table had a horizontal bar
Right.
underneath the shoulder.
Yeah.
Do you maintain
no,
that?
No shoulder bar, because there's a big debate.
In that case, it sinks. It tends to sink.
Yeah, Meta originally rolled the cast over the shoulders. Some of us always roll the cast over the shoulders. Some people don't include the shoulders. I think for lower curves, it probably doesn't matter. For higher curves, I think you need to go up over the shoulders. So that bar blocks you from putting your cast on. So there's a piece that their head rests on. But there's nothing below that until the bar that's underneath their butts.
No, with the wrister table, the bar is to come out. The
Come out,
horizontal
right,
bar.
exactly.
So
Yeah.
you can go over the bar and pull it out.
There are people, I know there are people in the States who, as they're getting started, I mean, the wrister tables in most hospitals in the States are in the basement somewhere. So they're.
It went for condemnation in
Yeah,
our
exactly.
hospital,
But so they drag them out of the basement and use the old wrister table until they get one. So you can do it with the wrister table. It's just easier with this new table. It's made more for kids.
Question?
I was trained by Nick Mehta in casting techniques long time ago, my training. Some of these curves which you mentioned were big curves, like curves 60 degrees, 80 degrees and beyond. In our experience in India as well, they turn out to be more neuromuscular curves rather than idiopathic curves.
Yeah.
Because even there in the Western world, when I was trained, I've never seen curves going into 60, 80 degrees. They fall into a different categories, sometimes very difficult to identify which category they fall into. And our experience here in the last 2 decades here is that a lot of them turn out to be neuromuscular with very flexible curves. And you put them in casts or whatever, they tend to, after you remove the cast or a brace, they just fall back, and they would require surgical techniques.
Exactly.
Yeah.
But and those kids, I think, are still good candidates, but you need to know that you're not going to cure the curve with the cast. But if I see a kid at age 3 with an 80-degree curve who we can keep at 80 degrees until they're 6 by doing the casting, I would rather do that and then put in growing rods or a Vector at age 6 than I would at age 3. Because I think, there's more and more evidence that the longer the rods are in, be it either Vectors or growing rods, the infection rate goes up enormously. Dave Skaggs has talked about the law of diminishing return. I think the more you lengthen growing rods, the more chance there is that you get autofusion. Issues with proximal junctional kyphosis are tremendous with both growing rods and Vectors. Vectors, you don't get spine fusion, but we're starting to make normal chests into stiff chests with Vectors. I mean, I think Vectors are great for kids with abnormal chests, but, we really don't know what we're doing to these kids who have normal chest walls and then suddenly sticking this big device on their chest wall and decreasing their chest wall compliance. So I think that those are all great techniques, but if you put them off as long as possible until the kids are older, I think it's that much better.
So would you call these kids with these 80-degree curves as idiopathic scoliosis?
No, most of them aren't.
So how do you classify them?
Well, I think some of them are I think some of them are neuromuscular. I think some of them have these funny congenital myopathies and things like that. Right. Some of them turn out to be syndromal. You work the kids up enough, they have things like Marfan syndrome. Right. So I mean, you do see idiopathic curves that big, but a lot of the really large curves, I think, tend to be either neuromuscular or syndromal.
Right.
Yeah.
Would it really matter, even if you had missed a neuromuscular, calling it idiopathic?
I think it only matters in that you know you're not going to get the curve better with the cast. You know, the evidence really seems to be in that paper that I was talking about from Shriners in Chicago. I mean, we really showed the idiopathic kids did much better as far as curative with the cast than the syndromal or the neuromuscular kids. So I think from a parent's standpoint, you need to tell them, look, we're not going to make this curve better. This is a holding action until the kid gets bigger. But no, I don't think there's a difference as far as whether you're going to cast them or not.
Your take on these 80-degree curves being neuromuscular, I mean, not necessarily, because because what happens if you look at the idiopathics, I mean, the Western people have stopped seeing the high grades idiopathics because they have the school training program and they pick it up. In our country, you see a lot of these 80 degrees, 100 degrees, 120 degrees. They're all idiopathic. Most of them are idiopathic. So it's just that when you interfere at them early, they stay flexible.
Yeah.
If you leave them on, then they become very rigid,
Yeah.
right? But they are basically idiopathics. Similarly, these early onsets idiopathics, if they get into the infantile group and you leave them on for 6 years without any treatment, as in our country happens, they would come with a stiff 80-degree curve.
Yes.
Having said that, you put these 80-degree curves, 90-degree curves on under GA and put a growth rod distraction, and they come down very easily to 30 degrees. You know, so that itself is a proof that they are neglected idiopathics, just like adolescent neglected idiopathics. These are infantile or juvenile neglected idiopathics. That's how I look at them. And some like you rightly said, some of them are syndromics.
I agree. We have to assume that they are idiopathic because we can't find anything else. But as I said, you know, we all see these patients, and now, as you know, I'm also into growth rods because we're also fed up of putting them into plasters, which we have gone through this, and then put them in braces, and the curves are progressing. And we have a problem of these patients coming suddenly at the age of 18 with a 140-degree rigid kyphotic curve.
Mm-hmm.
So we are now progressing towards growth rods, and we all face the same problems as you have just mentioned. But we don't have a diagnosis to understand a 80-degree curve in a child less than 6 years, who is otherwise normal. What do we call them? We don't know. A lot of them could well be idiopathics because we have no evidence to prove one way or the other.
Remember, majority of them are main thoracic curves, right? So they are idiopathics. And if you're looking at paralytic or neuromuscular, they would be a big curve. These are not big long C curves. Majority of them are not. Yeah. The other things, that other telltale signs of neurological deficits are not there in them at all.
Not there.
So what are they? They're basically neglected idiopathics who have become who had an onset and juvenile or infantile age group.
Yeah.
Okay, thank you, Peter. That was a great presentation. I call upon Dr. Viral Jain for the next talk. There seems to be a huge resistance in our country anyway to casting, and it seems like all of us need to read that paper. And has anyone done casting in your career? I mean, you have.
In kids in India, their compliance is very good. If the mother is convinced, the parents are convinced that this is the answer, they'll go ahead and do it. You know.
Not surgery, yeah. Casting techniques. Because we need to learn, it's not good enough to read the paper. We need to be there and see how it's done, what table, how much force, and
I think we need to have a workshop or something on just on casting as such. It's totally forgotten here, I know. And we should do it maybe in one of the ASICONs.
Because we've got tons of kids,
tons
of little kids with
ASSI. And the problems here, as like you rightly said, the research tables have gone, discarded now, and we don't have proper tables, So these need to be worked out actually, yeah.
Okay, so Viral has all of 15 minutes to discuss what, mostly this is discussed over 3 days of an EOS meeting. Surgical techniques in early onset scoliosis. Over to you, Viral.
Thanks, Abhay. I'd like to thank Senthil as well for inviting me. So as we sort of had the introduction about early onset scoliosis, the problems, we do not have great solutions. So I'm going to show you some of the results, and most of my talk is focused on complications, honestly. Growth of the spine, most of our understanding for spinal growth comes from the work done by DiMaglio. And so you can divide spinal growth in 3 age ranges: birth to 5 years, 5 to 10 years, and then 10 years to skeletal maturity. This is a rough guideline. So you can see for first 5 years of life, the spine grows pretty fast, and then again when you enter in a puberty, it grows fast again. So between 5 and 10 years of age, your spine sort of slows down a little bit. This is a slide borrowed from DiMaglio, and you can see that at the end of age 5, you have about 15 centimeters of growth left in the spine itself from T1 to S1 segment. On the other hand, spinal canal reaches to its 95% of the size at age 5, and there is no further growth beyond that. So it's basically believed that putting pedicle screws in kids who are over age of 5 should be safe enough so that we do not cause any iatrogenic spinal stenosis. I know people have done instrumentation in kids younger than that, and they have not had any problems. So growth of the lung and thorax, as you can see here, from newborn to age 18, there is considerable growth. It's usually volumetric expansion. And from newborn to adult size, it's 14 times more volumetric growth. And even from age 10 to 18, it's twice the size in terms of its volume. So even though we consider that the spine reaches to most of its growth potential by age 10, the thorax continues to grow. The growth of the lung occurs by volume expansion and tissue hypertrophy, and as previous speakers have pointed out, the alveoli tend to grow or increase in numbers up to age 8, but beyond that, most of the growth from lung perspective is the expansion itself. So what is early onset scoliosis? Previously, we used to divide into 3 categories of scoliosis: infantile, birth to 3 years, and then juvenile, 4 to 9 years. So those 2 were considered as early onset scoliosis. But these classification applies more for the idiopathic patients, and I think in the early onset scoliosis, there are a bunch of different etiologies. So currently, we consider any scoliosis which has been diagnosed before age 10 as early onset. However, most of our talk is basically focusing on those juvenile and the infantile onset curves. As Dr. Sturm pointed out, up to 18 to 26% of those patients who have early onset curves will have some MRI abnormalities, and those need to be identified. Usually the clinical examination is normal, but in our experience, the most common abnormality that we have seen is asymmetrical abdominal reflexes. So in a patient, even if you don't have enough time to examine them completely, especially in their motor examination or sensory examination, you can almost always do an abdominal reflex examination and you can look for the trouble. We usually like to get MRI only if we are planning to do any sort of intervention, especially surgical intervention. So natural history has been well studied. Rate of progression, depending on the age of the patient and the onset, is 5 degrees per year to 20 degrees per year. And if these curves are left untreated, they tend to get really serious and they interfere with their pulmonary development. So prominent scoliosis before age 8 is associated with increased pulmonary complications and compromise and eventual death because of respiratory failure. So mortality is basically based on the age of onset rather than anything else. So if you control the curves in the statistics, if you control for the degree of the curve, and you eliminate that, then the age of onset is the most important factor. So difficulties in management, you can't really do a spinal fusion because it basically restricts the growth of the spine and secondarily restricts the growth of the thoracic cage, and that can ultimately lead to pulmonary compromise. So even though you are correcting the curve and trying to make it better, you end up causing pulmonary problems itself. And then again in the somewhat older kids, when they enter in their growth spurt, they usually have problems with crankshaft. Now this is becoming less common with modern instrumentation system, but it is still there for younger kids. So early fusion definitely leads to decreased PFT and quality of life score, and this has been studied even recently, as recent as 2008. And according to a study by Carroll et al., thoracic fusion of greater than 4 segments was considered to be a higher risk for development of restrictive pulmonary disease. And then crankshaft is basically bending of the fusion mass even though it's really solid, and or 10 degrees or greater progression after the fusion. And classical recommendation to prevent this is to do combined anterior and posterior fusion. So treatment modalities are non-surgical, which we already discussed, and the surgical are non-fusion methods. So non-fusion surgeries have been recently been classified into these 3 categories: distraction-based, guided growth strategies, and compression-based strategies. So distraction-based strategies basically arise from Hutter-Volkmann's principle. Growth stimulating effect of a distraction or a growing rod has been proven, so it's not just pure distraction, but it also causes growth of the spine as well. And it has been studied as recently as in 2012. So what are growing rods? The goal of a growing rod is to achieve deformity correction as well as to maintain spinal growth. During the treatment period of the growing rod, there are frequent what they call as lengthening procedures to adjust and accommodate for the growth of the child. So this isn't anything new. It has been described first in 1984, where Minneapolis group actually used Harrington instrumentation in a subcutaneous fashion without doing fusion. The problem was that the instrumentation itself was not really ideal to suit these purposes, and they basically had such a high rate of complication, they basically recommended that it should not be used at all. It was basically brought to a new life by Akbarnia and George Thompson, and they started using dual growing rod technique. So indications currently are curves greater than 50 degrees and failure of conservative treatment, which is brace and or cast. Age of the patient has to be less than 10 years because otherwise it's not worth doing these complicated procedures. And the thoracic curves are treated earlier, especially if you see an early onset scoliosis. These rods can be used for multiple different conditions. It's not just for idiopathic. So the technique is basically as in this picture. So initial procedure, you prepare the foundation sites right here at the top and the bottom, usually 2 or 3 levels, and you can use hooks or the screws as anchors. Then you do the contouring of the rod, which is the most important step to prevent problems with sagittal imbalance and junctional kyphosis. You insert the rods in subfascial or subcutaneous fashion. Usually subfascial is preferred. And then you insert the connectors. You don't have to use the proprietary connectors from the various companies. You can use a rod-to-rod connector, and you can still make a growing construct out of it. And then it is recommended to do bracing for 4 to 6 months to prevent failure of the instrumentation. Now, the thing that we have to remember is that you still have to do fusion at the top and the bottom to have a solid foundation. So this is using the hooks, as you can see, and you do a limited fusion in this area, both at the top and at the bottom. And then there are various ways of inserting these rods subcutaneously or subfascially. Either you can make a long incision and then go laterally and do the dissection and make sure that the rods are subfascial, or you can do a tunnel as well, which is what we prefer to do. So lengthening procedure, it's basically loosening the tandem connector and doing the distraction. It's usually an outpatient procedure. And then once your goal has been achieved, which is basically if the patient is old enough that you decide that the patient is not growing, or the other indication would be that when you do a growing rod distraction procedure, you do not get any further length, so it's very hard to distract. Those are the the cases where you do the final fusion. You basically do the regular arthrodesis, you can replace these rods by regular rods, or you can put some additional screws in between. It's not always necessary, but the spine is usually very stiff, and most of it is already fused. So what is the role of spinal monitoring? The rate of neuromonitoring changes during the primary growing rod insertion is around 1%. Now, intraoperating neuromonitoring has been recommended for insertion surgeries. For growing rod lengthening surgeries, it's it's very close to 0% to see any changes in the neuromonitoring, and therefore it's usually not always necessary to do spinal monitoring when doing lengthening. In my personal experience, I don't have a lot of cases to tell you about, but in my limited experience, I did encounter, especially in normal idiopathic patients, did encounter spinal monitoring changes during the lengthening procedure. So I still do not feel comfortable not doing monitoring even when the lengthening is done. Biomechanically, dual rods is always better as compared to single rod, and the rate of complication is considerably reduced, but it's still very high. The choice of anchors has been debated, whether you should use hooks or the pedicle screws. Those people who are comfortable putting pedicle screws in the proximal thoracic spine, it is recommended to use pedicle screw based on the biomechanical studies. So screw-to-screw construct with cross-link using two-level fusion. So total 4 pedicle screws in a cross-link is the strongest proximal anchor. Most of your Cobb angle correction occurs at the time of initial surgery. It's not during the subsequent lengthenings that you get correction. So if you are inclined to do more correction, you should pay a great deal of attention while you are doing the first procedure to achieve the correction. So elongation usually occurs at a rate of about 1.5 to 2 centimeters per year. That's the maximum. I think most of the studies have shown that you can get growth out of or length out of the spine. And the recommendation for doing lengthening is at every 6 months, although not a whole lot of people actually follow this rule, just simply because, as Dr. Sturm mentioned, there is a lot of problems associated with using growing rods, and every time you make an incision on the skin, you increase the risk of complications. So this is one of a very proximal curve. It's a syndromic curve. I think it's the patient has a neurofibromatosis, and you can see decent correction. These are the connectors. The problem with using these proprietary connectors are that you cannot contour the rod properly, and then that's why you can have problems up at the top. This probably about 7 years of age. So it's pretty high complication rate. You can say almost all of these patients will have a complication during their treatment period: wound infection, hook dislodgement, implant issues, especially at the proximal junction or the proximal anchors, and proximal junctional kyphosis. Those are the things which usually are very common. Neurological injuries do happen, but they are not that common. So just to show an example of a proximal junctional kyphosis over a period of treatment, you can see, it was a nice correction, but because there was no contouring, I think that was the problem right here, and the proximal hooks started to come out, and we had to revise them, and then we moved them down to a lower thoracic. But you can sometimes have uncontrolled proximal junctional kyphosis in this area. So neuromuscular scoliosis, treatment of SMA with growing rod has been really good. In our experience, patients with SMA2 usually have very good results out from growing rods. They usually have almost no complications from growing rods. This is the only group of patients that we have seen that have had no significant problems using the growing rod for a long duration. As you can see here, and it is mandatory to do fusion up to the pelvis, or your lowest anchor should always include pelvis to prevent problems later on. This must be around 8 or 9 years of age. So NF is the other group of the patients where you see early onset curves, and we did a study on 14 patients, and we got decent amount of correction. The problem was, again, proximal junctional kyphosis and failure of proximal construct. It is more common in patients with NF. I think it's partly because of their bone quality, and it's partly because of the kyphosis is almost always associated with scoliosis. So a patient with NF did really well after the insertion surgery, and over a period of time, as you can see here, even though we used proximal pedicle screws proximally, over a period of time, the rod sort of came out, and we had to replace one of the pedicle screw with a hook, and it continued on until we did the final fusion. So now switching back to Vaptor, it's a vertically expandable prosthetic titanium rib. It's what is called, and it's classically indicated for thoracic insufficiency syndromes. However, these syndromes are very rare, and we've used more often Vaptors for other indications off-label. So the first one is the rib to spine Vaptor, where this is the rib cradle, and this is Vaptor version 2. And then you put this as a supralaminar hook, and as is shown in this picture. You can use rib-to-rib Vaptor, which is primarily used for patients who have fused ribs along with scoliosis. And then you can use rib-to-ilium, which is primarily for those patients who have syndromes who cannot walk. So what you do, you basically do a paraspinal incision, usually it's vertical, and then try and retract the scapula out of your way, and you find out the ribs, and you basically go underneath and try to stay away from the pleura and prevent puncture of the lung while you are putting the superior cradle. It's technically is not that difficult. The problem with Vaptor is to how to manage them post-operatively and over a period of time. And this is what we did for this patient who was who presented at age 15 months. And we had to do what we did here, not at age 15 months, but we did have to do it pretty early in the life. So complications are prominent implants. These patients are usually malnourished and tiny as compared to the size of the patient. The implants are really bulky, and so you can almost always see them in all the patients underneath the skin. Usually the most problematic area is the superior cradle, where rib fractures and cradle migrates. Sometimes pelvic hooks migrate, especially on those patients where you have used them who are somewhat ambulatory and you have used pelvic hooks for them. Vaptor breaks, but it's not that common. Junctional kyphosis, which is the most common and almost always universally present in all the patients with Vaptor. Less commonly, the superior cradle migration or rib fracture can cause brachial plexus injuries. So this is one of the example of a rib fracture and or migration right in this area, as you can see. Kyphosis usually is the problem. Scoliosis usually gets stabilized from use of Vaptor. The kyphosis does not, and according to this paper, as they saw, the supple kyphosis becomes rigid during the treatment. The proximal cradles cut out, causing more problems. So basically, a relative contraindication to use Vaptor for a spine purpose is kyphosis or proximal kyphosis. So early extension of the construct to the second ribs bilaterally can help to stabilize proximal junctional kyphosis, and use of bilateral hybrid Vaptor, so rib to spine, can also help. You can use Vaptor for other indications as well. Spina bifida and NF is one of the indication that you can use because you do not want to go into the spine. The alternative to growing rods, you usually either use bilateral rib to pelvis or bilateral rib to spine Vaptors. And this is another patient who has neurofibromatosis. In this area, there is a lot of dystrophy. This is a dystrophic curve, and then a lot of dysplasia of the vertebral bodies. When we got the MRI, you can see that there is no way, there are no pedicles left because of the expanded dura. Although this patient is ambulatory, we had to use Vaptor for this patient. And we do not have a long follow-up, but you can see this is how it's been controlled. And the patient is so far doing well. So there are other techniques, guided growth or Sheila techniques. It's a growth guidance system that does not require repeated surgical lengthenings. It basically means that you control the apex, you do the apical fusion at 4 levels. Again, it is debatable whether you should fuse the thoracic spine at all or not. These are the specific or specialized Sheila screws, which are basically, this allows the motion of the rod through them. So over a period of time, as the spine grows, as you can see, the distance from the tip decreases, indicating that there is a growth. Compression-based strategies are spinal tethers, nitinol staples, and titanium clips. These are, I would say, honestly, more for the young adolescent idiopathic cases rather than for true early onset cases. And I think I would not discuss them, and I would not mix them with the early onset patient groups. And then, lastly, role of traction. It's usually indicated in cases where you have severe scoliosis, but also the patient has kyphosis as well. Rigid kyphosis is a relatively contraindication, or the absolute contraindications are cranial defects and C-spine abnormalities. And there are multiple complications that can arise, but these are usually easy to manage. The most important thing when the patient is in halo gravity traction, as you can see here, is to check for the neurological status, not only the lower extremity, but more importantly the upper extremity and the cranial nerves, because those are the ones which get usually injured initially before they start to develop a weakness in their lower extremities. So one of my patient, severe curve patient, has Dandy-Walker syndrome, but also has significant kyphosis, and that was the reason. This patient is only 3 years of age. We put her in a traction. So this is the traction film itself, but this X-ray is the more important one. This X-ray is done while the patient was in the wheelchair traction, just before we put growing rods in. And you can see this is a nice correction of the kyphosis after about 3.5 weeks of traction. And so we put her in a growing rod, and then you can see the halo is still on. The patient usually get about 3 or 4 months of halo vest after you do the growing rod procedure in these patients, and then you can discontinue them. So in conclusion, early onset scoliosis is a life-threatening condition because of its relentless progress and pulmonary failure. Spinal fusion is not a best idea to do in these kids. Cast and brace is useful only as a temporizing option, and growing rods can effectively control deformities and allow the spinal growth, but it does require multiple surgeries and very high rate of complications. Thank you.
Synopsis. By now, I think all of us have figured out how difficult these situations are, and it's like you want to refer it off to your, best friend. May I ask the first question? How do you decide the age limit to fusion rather than a growth rod? For example, the neurofibroma with a high thoracic, you probably could have got away with a short fusion because it was just a contained thoracic with a kyphosis. So what tempts you to go on a growth rod versus...
So primarily it's age-based. The decision-making is based on age. We almost always resist our enthusiasm to do growing rods or Waptor for kids or older. The really young kids, I think we tend to do more fusion, the growing rod procedures than the fusion. So I would say if that patient was not that young, then we would have obviously gone on to do the fusion. But I would say, for talking about that particular case, age 8 would be my cutoff. Anything under age 8, I would have gone for growing rods.
And location of the curve has anything to do with it, like a high thoracic versus a thoracolumbar versus one that's getting into the lumbar spine?
Well, I think if that patient had a lumbar curve, I would have probably done a growing rod, even though the patient is older than age 8.
Any questions from the audience? Sir.
Yes.
So one contraindication to fracture that you showed is onset of any neurodeficit in the form of UMN signs, a contraindication to your giving a pre-op fracture.
Well, we're going to talk about the severe rigid scoliosis in a bit, but I think you need to find out what is causing causing the UMN defects. So if the if the kyphosis itself is causing compression of the spinal cord, obviously you cannot use traction, otherwise you're going to cause complete paraplegia.
But I mean, I would think the contrary. You would actually ease off the tethered cord by straightening it if there was a deficit and your hands were tied in terms of surgery. Don't you think so?
So in those cases, I think rather than just doing a traction, I would probably do a first, a two-stage procedure where you do the release. You make sure that your spinal monitoring is giving you good signals, or at least unchanged from baseline when you leave the OR while you have put a temporary traction at that time. That it makes me more comfortable doing that rather than to put them in traction right away.
Anyone else in the audience? Sir, any question?
What are your, how do you manage them after they reach sort of maturity, 14 years, 12 years? Do you carry them without interfering, or do you routinely go in and fuse them?
So far all the evidence, I mean, honestly, it's not an evidence, but what most of the pundits would say that, you do final fusion, but there are centers that have realized that, when you take them for final fusion after putting the growing rods for 5 years, their spine is more or less completely fused, even though your intention was not to have the spine fused. So I think in coming years, the trend is going to be, it's your choice, or rather, how fair is. I don't think necessarily final fusion in those patients who had growing rods in for longer.
Yeah, like you were going in for all of them and fusing them at 12
Correct.
years or so. Now you're not. Now we are not fusing them at all. You're seeing them through, and they somehow do not pull off. That's what I was wondering. What do you guys do really?
So far, our practice is to go in and do a final fusion and do a revision of instrumentation, because there will be invariably a couple of levels where you would see quote unquote pseudoarthrosis, which is, pseudoarthrosis is a term when you have actually done fusion. But these spines autofuse, there are a couple of levels where you have autofusions where of the rods later on. So we go in and put bigger size rods. You don't have to put pedicle screws at all the levels or to try and get correction at the time of.
No, viral, but if they haven't broken for 6 years, 5 years, why do you expect them to break after another 2, 3
Exactly,
years? Why should
the,
you just carry them through, see what they
that's what I think that's what is going to be the trend. There are not a whole lot of patients who have gone through those 5-year period without having complications. So.
I thank Professor Jaiswal for co-moderating this session with me, and we'll quickly move on to AIS, and I invite our next moderators, Dr. Suresh Pillai from Cochin and Dr. Professor Nalli Uvra from Chennai, to take over proceedings, please.
After having listened to one difficult problem, that is early onset scoliosis, we next move on to the adult idiopathic scoliosis. And we first start with the lecture on, is there still a role for an anterior approach to spinal deformity? Yeah, it's by Professor Stom.
Gears here into a topic that I think is a little easier to deal with. Is there still a role for anterior surgery for spinal deformity? So traditionally, anterior surgery has been thought of as a means for deformity correction or combined release with posterior procedures. Initially, from an instrumentation point of view, it was introduced for thoracolumbar and lumbar curves, and then afterwards in the 1990s for thoracic curves. Initially, Dwyer in 1964 introduced his system, and then Zilke with a better, stronger system in 1974, but still the same concept. Anterior instrumentation, thoracolumbar and lumbar curves, short segment fusions, excellent correction. And the thought was that you could save levels by doing these anterior procedures, which, as we know, is probably a very good idea. The more motion segments you can preserve over time, the better. That said, I think there's more and more evidence, and we're probably not going to know the right answer for another 30 or 40 years until the kids were 13 now or in their 50s and 60s. But what probably is more important than saving levels is horizontalizing the end vertebra. I think if you can get the end vertebra horizontal, you're that much better off. I think if there's a wedge disc at the end of your construct, that's going to be problematic over time, no matter how many levels you have open. Charlie Johnston was the first one to really talk about the tilt angle and showed that there was back pain associated with residual tilt of greater than 10 degrees below the last instrumented vertebra at L3 or L4. And why that is and why 12 degrees should be worse than 8 degrees, nobody really understands. But it's probably just a matter of biomechanical stress on that last wedge disc. One of the problems with anterior instrumentation is that shortening gives you correction, but it also can cause kyphosis. And the question is historical lumbar kyphosis really as much of a problem as we think it may be? Study out of WashU in 1993 at SRS using Zilke instrumentation. Increased kyphosis noted in all patients after instrumentation. While kyphosis was felt to be a potential long-term problem, at the short term, after 2 to 5 years, it was felt that there was no correlation with implant failure or back pain based on the kyphosis. Similar study from Boston Children's with John Hall's old Dwyer and Zilke patients. Excellent correction. Kyphosis increased significantly over the instrumented segment, but no degenerative changes below the fusion was seen at the point that they had done the follow-up, and that was from 5 to 10 year follow-up. So using a solid rod and using a bigger rod may help decrease kyphosis. Study with 6.4 millimeter TSRH showed excellent frontal plane correction, and while there was some increase in kyphosis over the instrumented segments, it was much less than what had been reported previously. So we do have a way to diminish kyphosis, and that's with anterior column structural support, either structural graft, Harms cages, or carbon fiber cages, like here. You can see good correction and good maintenance of the lordosis using carbon fiber cages. I think if you're going to use anterior support or even anterior instrumentation, the key is really adequate disc excision. Bob Gaines talks about bone on bone. I think that's probably a problem. I think if you're going to use anteriorly, you want to use anterior structural support. But I think no matter how you do it, really taking out the anterior disc completely is the best way to make sure that you're going to get adequate correction and that you're going to be able to get a cage in and really maintain your sagittal plane contour. So again, another study from WashU, anterior support below T12, 72% coronal correction and maintenance of normal lordosis using anterior support. And a Longi study, 6 millimeter rod. Interestingly, no statistical difference in sagittal plane between those with or without structural support. And again, what they found was horizontalization of the last instrumented vertebra is probably more important than anything else. So this remains the question now. So we've all in the past thought that anterior instrumentation was best for the historical lumbar and lumbar curves, but Matt Geck's study out of WashU, Lenke 5C curves, wide release and short posterior fusion versus their previous anterior fusions. It was a historical cohort. Better correction, less last instrumented vertebral tilt with posterior instrumentation alone over the same levels that you would have done anteriorly. I think in my hands still, thoracal lumbar and lumbar curves, I think you get better rotational correction and better coronal plane correction with anterior instrumentation, but I'm not sure the difference warrants the anterior procedure. And I think certainly those of us who are a little bit older and have been used to doing anterior procedures, I think are very comfortable with it. I've always done my own anterior approaches, and I'm still very comfortable with doing it. fellows over the last 5 years, maybe see 1 or 2 a year. So I think it may be a dying art form. So more people, I think, in this day and age are more comfortable with posterior procedures than with anterior procedures, and that may determine this as much as anything else. So for a while in the 1990s, Harms first introduced this concept of anterior instrumentation for thoracic curves, and his thought was if shortening causes kyphosis, and that's a problem in thoracolumbar curves, but thoracic curves are hypokyphotic, maybe we have this backwards, and we should be doing anterior instrumentation for thoracic curves, get correction, increase kyphosis, and get better sagittal contour and sagittal balance. And then people started doing anterior instrumentation for thoracic curves. People felt it avoided decompensation, gave you better rotational correction, better sagittal correction, and let you save levels. And in thoracic curves, I'm not sure that's as important, but that was the theory behind it. Theoretically, in the past, anterior releases were advocated for stiff curves with less than 50% correction on bending, or curves greater than 90 degrees, or to prevent crankshaft in younger kids. I think the fusion level issue was easier when you instrumented anterior thoracic curves, because in posterior instrumentation, I think there are still lots of different rules. Moe and King developed their rules, which were based on distraction instrumentation with Harrington rods. Then the Lenke classification system came along, which really is a surgical classification system, and how to think about where to stop your instrumentation. Suk has introduced his criteria, which are different than all the others. But anterior instrumentation was simple. You just instrumented the curve, and that was the end of it. And again, AIS is associated with hypokyphosis. Anterior instrumentation is kyphosing, so why not go anteriorly? I think there are 2 ways of doing it. There a double thoracotomy, because you couldn't really get at the whole spine through one thoracotomy, so you did a high thoracotomy at about T5, and then another one down at about T11. You took out the 5th rib for graft, and in the lower one, you just didn't take the rib out. You just went between the rib spaces. I think it was a big surgery, but I think the results were very good. And then certainly for simpler curves, thoracoscopic instrumentation got very popular. The problem with thoracoscopic instrumentation, I think, is that there's a very steep learning curve. I think even in the best of hands, it increased OR time. I think compared to open techniques, there was less derotational and sagittal control. There was increased chest tube drainage compared to anterior open procedures. And the concern was the proximity to the aorta. The first reports were reasonable, except that the fusion wasn't great. So this is one out of Oakland Children's, 50 patients, 62% correction, but a high pseudoarthrosis rate because they weren't using autograft. And I think the problem with any thoracoscopic instrumentation still, mucus plugs are still a big issue.